Hello everybody, and a warm welcome to our second spotlight topic for biocompatibility of medical devices. My name is Anja Remisch. I'm toxicologist and responsible for biological safety evaluation of medical devices at QTech. Today I want to talk about the analytical evaluation threshold, or short AET. I want to give you a short introduction on the definition, the calculation and the impact of the AET value on analytical testing and biocompatibility assessment. As manufacturer of medical devices, you need to know what kind of materials, processing aids or impurities are incorporated in your medical device, and which health hazards might be associated with the material used. Therefore, the material characterization plays an important role during the biocompatibility assessment. Often not all data gaps can be closed during material characterization. In this case, the chemical analysis of extractable and leachable compounds is the next step. Here you can analyze organic and inorganic compounds that can be released from the medical device under exaggerated or simulated use conditions. The approach of material characterization and chemical analytics are described in the ISO standard 10993-18. This standard was actualized in 2020. To guarantee the sensitivity of analytical methods, the analytical evaluation threshold was implemented in the last version of the standard. The analytical evaluation threshold was defined first for drug impurities coming from packaging, for instance. With the introduction of the new ISO 10993-18 standard, the threshold was also introduced for extractable and leachable compounds from medical devices. It is an identification threshold. That means it defines a starting concentration when extractable and leachable compounds needs to be identified for the following toxicological risk assessment. With other words, the risk for systemic toxicity below the threshold is defined to be negligible. But how is the analytical evaluation threshold defined? For calculation of an AET value, you need the following parameters. First of all, a dose-based threshold for safety concern. In this case, the lowest acceptable value from the threshold of toxicological concern. The number or surface of devices extracted during analytics, the uncertainty factor of the analytical method, the volume of extraction solvent used for analytical testing, and last but not least, the knowledge of the intended use, including the maximum number or surface of your device used simultaneously for the patient and the duration of contact. The dose-based threshold is based on the threshold of toxicological concern. The default limit value was originally defined for impurities in food with known structure but insufficient toxicological data. Based on a great number of chemicals with known toxicity, structural alerts were identified for systemic toxicity. Based on these structural alerts, substances with known structure can be divided into 3 karma classes with different risk levels. For genotoxic substances, an additional limit value of 0.15 microgram per day was defined with an estimated risk of cancer with 1 in 1 million people. For medical use, the limit value was increased by a factor of 10, resulting in a residual risk of 1 in 100,000. The ICH guideline M7 adapted this value for exposure durations of 1 month to lifetime, resulting in limit values between 120 micrograms per day and 1.5 micrograms per day. But be careful. Some substance classes like metals, proteins or nitrosamines are excluded from the TTC limit values. To define the dose-based threshold and calculate the AAT value, information from different players are needed. The duration of use, frequency of changing, the maximum product sizes and the maximum number of devices used under clinical conditions needs to be provided by the manufacturer. Whereas the volume of extraction, amount of devices extracted during analysis, and the uncertainty factor of the analytical methods should be given by the analytical laboratory. To prepare an appropriate limit value, a good cooperation between manufacturer and laboratory are necessary. Based on the AAT value, further adaptation of sample preparation might become necessary to increase the sensitivity of the analytical method. To get the right threshold, some aspects need to be considered. First of all, a good knowledge of the intended use is necessary. Only if the clinical exposure can be clearly described, the calculation is a good estimation. For usage of the TTC concept, some substances or substance classes need to be excluded, like metals or proteins. Therefore, the AAT is only relevant for determination of organic compounds. Some high-potent genotoxic substances like nitrosamines are also excluded from the TTC concept and needs to be excluded based on the material used for your device. For devices with different product sizes, it might be more appropriate to calculate the AAT based on contact surface or mass, not on number of medical devices. If you include very sensitive patients, like children or neonates, for your device, the dose-based threshold might be adapted based on the body weight. Devices with high contact surfaces and/or long contact duration results in very low AAT values, resulting in a refinement of analytical testing, since the AAT value needs to be higher than the limit of quantification. So what can be done to increase the sensitivity of your method if the AAT value is very small? If possible, you can decrease the extraction volume. However, the extraction volume is limited by the fact that the medical device needs to be totally surrounded by extraction solvent. The second possibility, and this is the most used method, is to decrease the extraction volume after extraction. This method might result in loss of volatile extractables or might result in precipitation of the extract. Another method might be increasing the sensitivity of the analytical method by using other detectors or increase the separation availability of the method. However, these changes need to be validated. As you can see, all mentioned possibilities have their limitations. Therefore, the calculated AAT value should be as high as possible. So what is the outcome of the implementation of the AAT value? Based on the implementation, in many cases, adaptation of the analytical method became necessary. However, the adaptation of extraction method and sample preparation have their limitations, for instance, precipitation, degradation products or loss of volatile compounds. The higher sensitivity of the analytical methods increased the detectable amount of substances, resulting in a greater effort on toxicological characterization. I hope you enjoyed the short presentation on analytical evaluation threshold, and you understand the great impact on the biological safety evaluation. If you have questions or need more information, please contact QTech or me. Looking forward to hear from you. Bye bye!